Our next panel will focus on interoperability, which is often thought of as the ability for an organization or system to share information seamlessly with each other. However, that term also includes the ability for organizations to share information directly with a consumer. Through the CMS Patient Access Rule and ONC Information Blocking Rule, the federal government is making policy strides against information blocking and towards national interoperability, with a focus not only on inter-organization interoperability, but on patient access as well. And with the release of the second draft of TEFCA in April, HIEs across the country are preparing for a dramatic shift in the national interoperability landscape. Moderating this panel is Dr. Mike Zaroukian, Vice President and Chief Medical Information Officer at Sparrow Health Systems. He's a practicing general internist and board-certified clinical informaticist with deep experience in EHR implementation, optimization, usability, and return on investment. Dr. Zaroukian is immediate past chair of the HIMSS Board of Directors and past chair of HIMSS North America Board of Directors. He currently serves on the Virtual Health Data Trust Steering Committee, part of the National Academy of Medicine Leadership Consortium for Value and Science-Driven Health System. Please help me welcome our panel, led by Dr. Zaroukian.
I can work on switches, it's awesome. So hi everyone, thanks for having us. I'm of course Mike Zaroukian. I'm here to help moderate this session with Dr. Gettinger and Dr. Rosenberg. The format for this is obviously conversational. I'm basically going to try to stay as open-ended as I can in my questions. Usability, interoperability, health information exchange is a very big topic, and so I want to try to queue up a few questions, and then let's see where the conversation goes. So if I could start, I'd like to first begin with the overall perspectives. We have here two very expert individuals, probably coming to us from a couple of different perspectives. One, obviously, both deep in operational experience, but also now at a health policy level, and some incentive type programs and proposed rules and the like. And the other, deeply within an academic medical center with a large footprint, who's also involved in helping to create not only the clinical aspects of interoperability, but the infrastructure and the processes for paying for the kinds of technology that make this happen and then allow us to talk with each other. In my role, I'm a primary care physician who also happens to be a chief medical information officer and a chief transformation officer. So with any luck, we'll be able to give you a set of perspectives that will help. If I can start, I'd like to basically just give each of our speakers an opportunity to share their overall views on the important aspects of interoperability as they're seeing them in their environments, and then we'll try to build off of that. So I wonder if I might start with Dr. Gettinger and go from there.
I'd be delighted to avoid the I'm from the government and I'm here to help kind of statement. And before I get started, I obviously want to thank folks here from Michigan HIMSS, MiHIN, and all of you. This is amazing. I don't know how well you understand that you all rock in this space. And one of my favorite examples has been Maryland. Because of the great work they've done. Now I'm substituting Michigan for Maryland, so congratulations. And I'm going to say that in life you don't get any do-overs. So if we were able to go back to 2009, look at the Meaningful Use Program and say, how would we change it today? I think we would have, with today's insights, changed it to require more and more interoperability early on and not some of the things that we did. And I am in no way, shape, or form critical of the folks who've come before me. They are incredibly well-meaning and did great work. There's been a lot of work, a lot of noise about clinician burden. I'm leading an effort at HHS to report out on that, report back to Congress what we can do. You will probably see some of the themes that came out of our collaboration with CMS in the clinician burden report reflected in both their proposed rule and our proposed rule. So we didn't wait till we, dotted the I's, crossed the T's, finalized it. We actually have started making the kind of changes that we believe are essential. I think I'm going to also sort of deviate a little bit from, you've already heard from two of my colleagues talk about some of the work we're doing in TEFCA, some of the other work we're doing, information blocking, some of the NPRM. So I'm going to assume that most of you were here today and you don't need me to do that again. So what I'm going to suggest is a little bit of a worry that I have. And we were talking about it just before we started. Be careful what you ask for. And by the way, you're talking to two anesthesiology intensivists and only one primary care provider who's still practicing. So take that from where it comes. By the way, just parenthetically, I'm Andy, he's Andrew. Our names should be flipped in terms of our first names on the slide. And we've known each other for probably longer than I'm willing to admit.
10 to 11 years now.
10 to 11 years. Well, that's not bad. So I worry about interoperability in terms of how much content comes across that is duplicative, not helpful, and quite frankly stands in the way of busy clinicians being able to care for patients. And so it is a be careful what you wish for, and there are some examples of that already. If you practice and you look at a med list which has been compiled from a number of sources, it is clinically not friendly. It's very difficult. In the last administration under Vindell Washington's guidance, we went through an effort to try and improve that. Didn't get quite as far as we'd like, but I would suggest that that is the first hint that interoperability has, in addition to the great positives that we all imagine, has the potential for negatives as well. So I want to be thoughtful about what we achieve with this rule, what we achieve on a go-forward basis, so that clinician burden doesn't increase, but actually goes down. And we can talk about a variety of things in that space. We can talk about EPCS, we can talk about PDMPs. That's even more challenging because it involves not only federal rules, it involves state rules and state decisions and state statutes, which are not easily managed. We could talk about prior authorization, which after documentation requirements was the most commonly cited burden that folks were feeling. So that's just a little bit of an introduction. I'm going to stop here and let my colleague Andrew take over.
So it's near the end of the day, and I want to be a bit provocative and stimulate maybe some discussion or even some passion. I think you need to slow down interoperability. And one of the reasons is that you and I don't really know what interoperability means. It's not from the perspective of a physician, as Andy said. It's not from the perspective of a innovative payer, as I find Blue Cross often in supporting a lot of our state innovation, CQI, PGIP, and other things like that. It's not from the perspective of our innovation within MiHIN and GLHC and much of those other things. It's not from the perspective of a faculty member, of a parent, of a colleague, of a patient. It's the perspective of a CIO. We can't pay for it. We can't implement it, we can't upgrade it, we can't secure it, we can't prioritize it relative to all the possible current opportunities of interoperability that we have. So the challenge for you, the challenge for us, is what really is the priority. I'll give you an example. One of my previous fellows, who's at Emory, asked me if we could transfer a recent CT angiogram of a patient done at University of Michigan to Beaumont, because a patient's having hemoptysis, they're bleeding, they're coughing blood, and they're concerned about a very specific thing called a fistula. We can't easily transfer images. So there's just one example of a very concrete example. Now, there are a variety of ways that we could try or what we could do, but the reality is something as basic as that, we're not doing it routinely, reproducibly. So there's just one example of how about that as a concrete step. So I say that, and I hope that we'll have some discussion about it. The challenge that I find as a CIO is not the desire, the aspiration, the vision. Who's going to do it? Who's going to upgrade it? Who's going to pay for it? Who's going to secure it? And who's going to prioritize it relative to everything else? And I'll end with this, and this is, I told Andy that I would be provocative. We have too much legislation coming at us right now. We have too many NPRMs. I don't know how to handle several of the conflicting aspects from very understandable aspirations of the new ONC rules, changes to HIPAA, CPC plus. But the reality is, whether it's some of the exceptions that we are very likely to call out and the ability to, in good faith, try to meet expectations, but then also call out exceptions that are important to us, security. Let me put it to you this way, and then I'll stop. When the ONC proposed rules came out, I received 3 phone calls within about an hour from 3 CEOs of 3 consumer-oriented patient groups, all saying, this is the moment we've been waiting for. Isn't this great? All the work that we and many of you have done around open APIs, now you're going to be able to use these data. And I said, there is no way we can turn on those fire hydrants the way you want it. And I could tell already we were now in an area of conflict. So hopefully within those kinds of those points will be areas for us to discuss some things.
So thank you both. Clearly nothing much left to talk about. So I'm having palpitations just thinking about how this has impacted my practice already. So in full disclosure, I was part of the Meaningful Use Work Group that drafted and crafted the initial rules and regulations for this. I have a very strong crawl, walk, jog, run philosophy. I'm a marathoner and ultramarathoner. I know that if you try to sprint this stuff, you will die. If you fail to pay attention to all of the things you need to do to survive, like hydration and nutrition and footwear and good form and all that, you'll have the same issue. So to me, that's the metaphor of what Andrew is talking about with regard to making sure we have in place what we need to, so that when we do get what we're asking for, we're neither overwhelmed by it or underwhelmed by what we're getting. And I don't know if there's any practicing providers out here, but for example, I am still waiting for the very first immunization that I'm getting through the interfaces that I don't already have. And if you think about the number of patients we might see in a given day and the number of things that are finally coming across interfaces from one organization to another, some of which are well recorded, some of which are terribly recorded, and none of which yet are coming directly from the MICR registry through a two-way process, although we'll be there soon. You get a little bit of a taste of what this is like. Similarly, if you don't have a highly usable tool for comparing similar medicines that are not enough identical for the EMR to know this is an exact match and you can therefore ignore it, you have other issues. And then the final thing I'll say before I try to go back to the positive side of this is I thought as a primary care physician that other people in subspecialties were probably taking better care of their problem list than they do. So, for example, now that we have 2015 certified technology and more people are required to have CCD architected documents that are then coming, and those will include some structured things like problem lists, it's amazing to learn that ophthalmologists may have problem lists of 24 items, with 22 of which to me don't look significantly different from each other, and yet I need to sort of figure out what to do with those. So having said that as a cue up maybe to some additional thoughts they have, I do want to focus first on, given where we are today, what have you seen as some of the big wins? I certainly have my perspective on what some of the big wins in interoperability have been, but as the starting point of the benefits we've received so far, what are you seeing?
You know, let me answer that in a way. When we were doing a lot of our implementations, I remember several of the providers saying, you know, the reality is I'm actually now getting HIE. We're getting medication and problem lists and some of the most basic elements through, we happen to be on Epic, but just the ability native within Epic to get that was an absolute carrot. In our environment where we had already had a patient-centric EMR, patient-centric problem list, patient-centric medication, there were not that many immediate carrots. The ability to very quickly being able to see those basic elements from many of the health systems that we exchange patients with was an immediate carrot in and of itself, out of the box, and I used that very explicitly, and this was now 4 and 5 years ago, as an immediate reason, one of the reasons why we're doing this.
You know, that's a great comment, Andrew. Within the same ecosystem, i.e. the same health IT developer space, there's been substantial progress. And I remember when we deployed that system from your neighboring state, it was early on, and their interoperability was very difficult. And in fact, some of the early adopters, Kaiser, other early, Cleveland Clinic, really had modified their systems so much that the interoperability didn't work very well. And I'm very impressed that over time that's gotten better. Where there's still challenges are where you're going from one system to another system. And too frequently that information gets segmented into encounters that are not in the clinician's workflow. So the focus, you know, we actually have some opportunities to prioritize, to have clinicians basically say what they need. And in fact, most of the organizations where the satisfaction level is high, that's exactly what's happened. And I'm struck, you asked for digital benefits. I almost sounded like Jonathan Perlin's commentary. He's a senior guy at HCA, and they've done a tremendous amount. But, you know, I'm struck by some of the early meaningful use requirements about electronic prescribing and electronic medication lists and allergy lists. And there was a study from Florida, Econos and Bay. It was a number of years ago now, but it's one of the articles that I think about frequently, especially when I'm frustrated, because those hospitals that adopted all of the medication-related meaningful use criteria, and this is the big and had medical staff who were enthusiastic about their EHRs, saw profound decreases in medication errors. Those institutions that adopted it, but their clinicians were unenthusiastic about the EHR, did not see the improvement. So there is some, as my friends in Texas talk about, socio-technical aspects to this. Right. That are not just the software. Now, I want to go back to something that Andrew said, though. You know, we have, where's the money going to come from? I am frequently, whether it's my colleagues at the AMA who pull out their iPhones and want the EHR to be just as simple as their iPhone, or whether or not it's a comparison about the ATM. I am so tired about the ATM comparisons. Yes, I have an ATM card. Yes, I can do 3 things with my ATM card. I can put money in, I can take money out, and I can transfer it. If we only had to do 3 things in healthcare, we could do that. By the way, healthcare on average, and the numbers bounce around a little bit, but if you look at hospitals, hospitals tend to spend about 2.5–3% of their operating budget on IT, health IT, and actually all of IT, but includes health IT. The banking industry, in order to go from that brick and mortar to where they are today, spent 12 to 15% of their operating budget for a 3 to 5 year period making that transition, and today spend 7 to 8% of their operating budget in IT. Now, what they're spending it on has changed a little bit. Now it's in anti-fraud and security, but it is a recognition that if you want to play effectively and smoothly in this space, there are real costs to it. Now, before you say, do you want me to have fewer nurses, older hospital beds, antiquated monitors, I understand, trust me, I was there. I understand the competition within that system, but I think too often we look at health IT or implementing an EHR as a capital project with attention from the Board of Trustees all the way down, incremental reports, very high visibility to then, now we're done. And we don't have the resources allocated to sustain that, to do the upgrades, to do the maintenance, to do the enhancements, to do what I think we do very poorly on average, which is support clinicians in the field. And the software has improved over the past couple of years. And whether you think it's Big Brother or whether or not you think it's your friend helping you, there are ways to identify those clinicians who are really struggling, meet with them, and help them so that they don't struggle as much.
One thing I want to follow up, and I think a lot about you in the audience, we're actually doing some things very well. And one of the things that I find with the executive group at the university is to remind them of that. Again, to re-emphasize, now that we're digital, the number of options are just growing. And so the sense of not keeping up, falling behind is somewhat of a byproduct of the ability to now do some things that we never did before. I was on a panel at Becker's and people were talking about how difficult the EHR is. And I said, hold on a minute. In your training and mine, we never had the ability to exchange records like we do now. So let's take a second to point out we're doing some things very well. Viper with GLHC is incredibly popular among our clinicians, and I expect others who are doing work with that. MiHIN's ability to help us start to see ADT messages, we never had those abilities. We should first start by saying we're doing some things extremely well. Now the question is, what else do we do? I have a very strong bias for one of our groups at the University of Michigan, the Michigan Data Collaborative, and hopefully you know about it. One of the challenges that Myron Hepner, Ellen Bunting, and I are dealing with now has nothing to do with the technical abilities. It's now some of the extra abilities around security, around identity management, authentication, as we have to try to deal with very complex interoperability issues. We never had to deal with those before. We were us, you were you, and we would send things in an analog fashion. We didn't have to deal with fundamental things like identity and access and security. So part of this, why I talk about slow down the train for interoperability, is we just have some very basic blocking and tackling now we have to do. The technical, the aspirational, those vision, those are all very solid, and we're fortunate, as Andy even said, the state of Michigan, when you go to other states, some things we take for granted around our shared collaborations with the CQIs and quality groups, they have nothing like that in other states. So I think what's important for us to do is to find those 2 or 3 key things that we need to be doing more. An example, in fact, a question that I was hoping that you might be able to help for us is, anyone from Trinity here by any chance? Oh, come on, no one, really? I was on a call with the MHA, the Health Information Technology Committee, and I was very embarrassed by the fact that we want to be using Care Equality with Trinity to exchange information in the Ann Arbor, St. Joe region, but partly because the University of Michigan is a constitutional entity, none of us can be the signature for one of the requirements in Care Equality in order for us to exchange. It's just impossible at the University of Michigan. That's one of those total one-offs that I think very few other organizations in the countries have to deal with, yet it's keeping us from using care equality to do something we would naturally want to do with a great partner. So hopefully with TEFCA, and maybe as some of these organizations become QHINs, we'll be able to get by some of these, because it's not for a lack of wanting to, it's not for a lack of having shared patients, it's simply for one of these one-off oddities, but we can't use care equality to do something that we would otherwise want to do.
Yeah, that's certainly our vision of TEFCA, to simplify things like that and to make it so that each of the entities that currently negotiate and spend money on a regular basis and time with these contracts, multiple contracts. So the notion is you do it once, everybody adopts a standardized contract, and then you're good to go. The information will flow. I think, you know, from what I've heard since getting here last night and speaking with many of you, you guys really are amazing. There are so many places in the country where information doesn't flow, and it purposely doesn't flow. And I'm not talking about the developers and charges. What I'm talking about are entities who view it as their competitive advantage not to share that information. And it's very, very clear that Congress has said, we will share information. You, ONC, can define a couple of exceptions, which we think we did. We're looking forward to the comments that have come in on that. But from the date that statute was signed, information should be flowing. And if it doesn't flow, it needs to not flow for a particularly good and validated reason. And you can't say that I'm going to share with you, Mike, but I'm not going to share with you, Andrew. So that's also very clear. So we're feeling pretty good about not only the rule, but what we've proposed in TEFCA. I'd also say in terms of the going slow, you know, as a nation, we had this expectation around interoperability starting in 2009. Actually, it went back to 2004 when President Bush talked about digitizing healthcare in the State of the Union. Anything that's mentioned in the State of the Union is a top priority. So 2009, so Republican to Democratic administration. 2009, all of you remember we were in a recession. Health IT, the meaningful use plan, the 36, 38 billion, depending on what number you're using. Investment was, quote, shovel ready. And so at that time, you know, the industry really transformed itself. And many organizations jumped into this space, and I would suggest that we now actually have the opportunity that you were suggesting. Now that we're all in this space, how do we refine it? How do we make it better? How do we make it usable? And you know, I'll be happy to come and talk to your bosses with you. You need more resources.
We could use money.
So, and it's going to, it is going to cost some resources, and I think the challenge is, what's the return on investment? And the return on investment is, and who benefits? And I think part of that discussion is a complicated discussion. And I've already heard some folks calling out earlier today to some of the third-party payers. Certainly the government will benefit if you talk about CMS, if you talk about some of the government as the biggest health insurer of our nation.
But you've heard me talk about, and I do it very explicitly, Blue Cross Blue Shield to me is an innovator in this state. You've heard me talk about other health systems that we work with, and I would say they equally would say the same thing. You've heard me talk about some very basic things like ADT messages and clinical images. I think one of the things that the state really can do, and this is my self-challenge, but I would say argue to us, is to focus on some of those things. To use MiHIN, GLHC, the state, whether it's also maybe some work with MICR and our immunizations and our opiate data, some very basic things that we still work together on. You've not heard me for a second mention fire. You've not heard me for a second mention the US CDI V1 data capabilities, because right now, I am very concerned when a third party will come to me and say, turn it on, keep your tokens open now for, think about Blue Button 2.0. I want it on for the entire year. And because I have these 20,000 patients, they've all given me consent, and I will focus on OAuth and your Fire API and open up your fire hydrant. Do you know where your data goes once it goes into one of those third parties, and then where? You don't. And that's a real concern for us, and that's an example of not the vision. The vision, I think, is actually a very good one. So anyone who's a third party out here, I'm not saying we don't want to. It's that compared to some of those more basic elements I just talked about, has so many unknowns and so many concerns. I don't think I'm sounding like information blocking. I'm trying to think about some of those exceptions that are in the proposed rule, because we all want to protect our patients' data. It's not so much that we're trying to hold on to it for some Machiavellian commercial need. It's, you don't know how we're going to be able to protect our data. And we're the ones who will then be under breach. We're the ones who will have reputational and real loss. And we're not ready to accept those risks yet.
Well, at the risk of being equally provocative, what we're saying is the patient's in charge. And we have been in healthcare, I would say in medicine, actually more than healthcare, very paternalistic over time. And if we put the patient in the center of the decision-making as to where their information goes, and it goes to places subsequently that are problematic, that is on the patient, because we believe that the patient should control where their information goes. And for so long, that's not been the case. And quite frankly, when I look at the quality of the notes that are being generated in inpatient and ambulatory settings today, they are fraught with error and problems. And we're not going to, we need another member of the team that that basically says, doc, no, I'm sorry, that's not accurate. Can you make that more accurate? Because right now, as I mentioned, I'm an anesthesiologist. I would see patients 2, 3, 4, 5 days post-op where the plan was to take them to the operating room tomorrow. And that's an example of the current system not being used in the way that we anticipated. And so I don't disagree with you, but when you look at time frames, when we finalize our rule, we've proposed a 2-year period before it's done. And we just required the 2015 edition, January of this year. So it's 2019, so that's 4 years later. It will take us some chunk of time before we adjudicate the regulatory process, and then from when we finalize, it's at least 2 years, and there are some industry requests to make it longer than 2 years. So we're looking at 2021, 2022, 2023, somewhere in that space before it's required, and we can then sunset some of the earlier versions of our rules. I don't personally, this is now Andy the person, not Andy the government, I don't believe that regulating is got the sensitivity to time and changes in our industry to be able to meet the need, quite frankly. So trying to find a way where we can do sub-regulatory guidance, where we can do consensus-based approaches, use other SDOs instead of our internal certifying thing, is the direction that we need to go in order to provide an ecosystem or oversee an ecosystem or not get in the way of an ecosystem that otherwise is going to move much more quickly than we can.
Okay, so a few thoughts I'll have from the other side of all of this. So and it'll speak to the next set of questions so that I don't just lecture like a professor that I am. But the part that strikes me on this, and again, it goes back to the meaningful use days. You know, when we first proposed some regulations, it was to create a requirement to do something because we thought it would at least be doable. The electricity would go on if you tried to make a problem list, and therefore we want to at least have you do some experience with that. And then at some point we feel like probably all the EMR vendors will make it easy enough to do problem lists that we can ratchet up the expectation. And then at the end of the day we can drop it all together because everybody's using it, and it has proven itself to be a reasonable expectation, part of what we all learned in medical school or our other health professions schools, and we could move on to the next thing. And I think it really speaks to Andrew's comment about when are we ready for what. The expectation that information move in an interoperable manner, because there is, again, both the infrastructure and then the skill and the will of organizations to do it and the financial resources to do it, I think is, again, one of those things that makes sense. And the key issue is, when are we ready to do what? You had mentioned earlier EPCS and PDMP, which I think Michigan, I'd love to hear maybe a question or comment from the audience as we move to that section in the next 10 minutes or so. But for us at Sparrow, that was a really fascinating thing because regulations came in to try to help make sure we were doing opioids and other controlled substances well. It came on the heels of the right technology being at the right place for those of us who were ready to simply say, it was nice to consider prescribing of controlled substances. Now it's probably a must, and we have the technology to do that. And oh, by the way, the ability to integrate into the state's PDMP, the MAPS program, is now fluid and usable enough in the system that we have the mandate to make it easy for people to do it right. And at least our compliance, and probably for many of you who've had the same opportunity, the ability to nail that health information exchange and interoperability was quite doable and quickly turned into something that we don't even have to convince providers to use because it was an obvious win to all of them. And compared to the expectation without that kind of movement forward, it would have been a big struggle. So as I think about what we're talking about, so we have a care quality link with our partners at Michigan State University who use a different EMR than we use at Sparrow, and it has both blessings and curses. I actually retired from MSU, brought all my patients over from that system to our system before we had care quality, and guess who manually put in all the problems, medications, allergies, and so on and so forth. So you're welcome. And then, 6 months later, when they had care quality up, the same flood of things came over. So that just proves the irony of timing. But I think that the key question is, as you think about our opportunities now going forward, and as you've described some of the unintended consequences, and as you've described the elephant in the room, which is some of what we're getting isn't very good. Whether it's data accuracy, data integrity, whether it's signal to noise ratios or other sorts of things, how do we mitigate the what we are capable of doing from what we must do, and how do we deal with the physician existential issue of, well, there is something out there from the University of Michigan or elsewhere. I actually do have more work if I want to be a responsible physician and review what's out there. So let me just throw that big gamish of ideas out there and see what you think.
Well, it's a great, tough, complex question. Maybe take it from two potential sources. The first is, I don't underestimate the fact that we're still at the beginning of a revolution and a big disruption. So for example, to Andy's point, the mess of notes, well, at the same time, and you well know it before, the opposite problem existed before. Wound clean, dry, and intact, see patient in AM, signature. That was a note that was not that uncommon from some clinicians. The cut and paste issue, I suspect, will change probably as much with technology and changes in how we actually think of a note, more as a wiki perhaps. More automation that allows those people who are creating the notes to not feel so overcome with documentation so that they cut and paste, which is a very rational behavior when you're really just trying to chew through 20 notes. Some degree of AI, which will start to strip out key elements and start to represent data in a much more meaningful way. I think all of those will be elements that will evolve over time so that we have enriched information. At the same time, we'll have newer users. We'll have people who've grown up with these technologies, not many who have transitioned from one fundamental workflow to another. But the other, and I keep coming back to this, is we have to focus on what those key priorities are. Right now, and you hear me say it all the time, I put on my intensivist hat where I will constantly say, with all of this complexity, what is that one thing you want? Because right now I hear it's dozens and dozens of things, but no, what is that one thing you want? Is it the ADT message that's really enriched and accurate? Good. Because I happen to think that's not a bad use case, that we pretty much all want that. There are a lot of use cases that come off of it. But start there, or like you heard me say, a reasonable method to transmit images, because we're actually doing okay with problems and medications, or even when we get the mess. And, you know, Mike, your point is excellent. At the same time, I would rather have the mess of all that information where I can try to, than an absence of it. But then to one final point, and I'm going to hopefully be having dinner with Andy tonight, so I need to be very careful about this next comment. I don't think our patients know how to handle their data. That is paternalistic. I recognize that. But I also know from experience, from objective measures, very few of our patients really ask to see their medical record. And don't misunderstand, I'm not for a minute talking about because it's so wonderful and so accurate they don't. At the same time, I don't think they know how to handle the complexity of health-related data. So while I fully agree it is their data, I do not agree that they should then have this unfettered access, which is where I see some of the legislation pointing, because I think we're going to run into a lot of problems. I don't want to know the aircraft data when we're flying. I'm not an expert. I want experts to handle it and to keep me involved, definitely, but they don't know how to handle their data. I think they should have access to it, don't misunderstand. But I don't think they actually really understand the implications of making those data available to other groups. And that, to me, is something we need to, slow our roll just a little bit.
Okay, so you're paying for dinner, that's for sure. Oh, I can't do that.
You can't do that.
I'm a Fed. I can pay for your dinner, though, but you have to change some of that language. So, I want to talk in a more positive sort of, vision coming forward. We are approaching an epoch in clinical care where the content that a treating clinician is going to need to assimilate is beyond the scope of an individual, whether it's genomics, proteomics, what the interplay is with all the conditions that a patient has. It's why I think AI or machine learning, which is sometimes preferable, at least Dr. Rucker thinks that's a preferable term, so I'll use it, machine learning, is necessary. And to date, it hasn't been very good. I first saw a demonstration, and I'm not being critical, of IBM Watson 7 or 8 years ago. I've seen it every couple of years since. I'm really enthused about their work, but it's not ready to make a difference in most clinicians' practice. I've seen some demonstrations of what Google is doing with these very marginal notes that have all kinds of inaccuracies, and it's amazing some of the insights that they're deriving from that content. And if you then start saying, well, I've got to now blend in the genomic makeup of the patient in order to know which drugs to prescribe or not prescribe or what to expect in terms of outcomes, it's more than a reasonable clinician's going to be able to do on their own. So I'm of a vintage that, Star Trek, Bones. You don't have to touch me, just hold that thing over them. The vision of the treating clinician having their clinical skills augmented by technology is one that I think I continue to have. And as we get closer and closer to that, the old way of doing it isn't going to be adequate. We won't be able to do that. And I think the problems, as a former CMIO, who got nailed every time the Joint Commission came through and said, you don't have a functioning problem list. And I struggled because our internists wanted a problem list and our specialists were much less convinced that they needed a problem list. They were just being very focused. So again, thoughtful, just as you've said, Andrew, thoughtful views on what we need to do, what we should do every single time, and make sure it's done accurately, I think will get us further than trying to boil the ocean at the outset. So we actually agree.
So let me ask you a question. As hopefully you've been able to see some of the actually very nice infographics and data on some of the proposed rules from ONC, but I don't think any of you have read through the several thousand pages of the actual rule. I know, Andy, I'm sure you have, but...
excuse me, our rule, 700 to 800 pages, depends what size font you use, and I can make it even fewer pages by using smaller font.
What is the intention of the idea of the IT developers, particularly some of the big EHR companies, to make the entire patient cohort's data available for transport, for example, to another platform?
Since the Meaningful Use program started, we obviously track how many certified developers there are. You need to be certified in order to qualify for CMS incentive programs or other CMS initiatives. The number of developers has dropped and continues to drop as the marketplace has consolidation. What we have received and heard about and received more about is the inability to move patient information from one system to another system in these transitions. So our effort is to ameliorate that particular problem. And then there, in addition to that, there are have been substantial costs imposed by developers to do some of that movement that have been very challenging, especially for small organizations. Not that you don't have legitimate financial issues, you're a big organization. Our thinking is the individual or small group practice, you know, everybody always wants to say rural area, there are as many inner city small group practices as there are rural ones, but those practices, I think, are even more challenged than some of the large healthcare systems when their software goes out of business. We had the privilege of having Dr. John Fleming for 2 years with us before he segued to the Department of Commerce. He came off the Hill as 8 years as a Republican congressman, and he's a family practice doc who his practice was on its 4th EHR. And each time they made a transition, they struggled because of this lack of interoperability. So that's what we're trying to do with that provision.
So with that, being in the middle of transitioning one of our practices from one to another, that's certainly a pithy and important issue because data extraction is a tough challenge, and interoperability would help an awful lot of that, I'm sure. And for us, the investment in that, trying to move that forward, is probably less than just moving them over to the same system. But I think to that point, if we think forward in a positive way to the opportunities going forward, part of what I'm hearing is how do we bring along those currently left behind or who are more challenged either through finances or technology or leadership or whatever it is. And then what do you see to be the biggest, highest priorities in the next few years with regard to the steps forward in interoperability that'll have the biggest impact? What are your perspectives, each of you?
Well, one for us is, I think, the promise of the open API. I've been just even personally playing around, quite frankly, with blood pressure cuffs and scales and just getting a little more familiar myself with what that means, and then trying to track how that data goes. So on one hand, for example, we were looking at a lot of pharmacogenomic diagnostics last week. We were talking about where they're getting used at the University of Michigan to try to get a sense for patients what kind of classes of medications will be very likely to be effective, moderately, or potentially ineffective at all. The tools that I think we're going to be using will both be native to our EHR, but also more likely secondary tools that we'll be using are open APIs to access and to deliver data to patients and others. How we're going to do that work, the governance, the priorities, the things I mentioned before also still have to be worked out. My concern is right now if someone comes to me and say, by law, you have to just expose your API, which by the way we do, and then not really knowing where those data go. I saw a really fascinating discussion about this that we then looked at. We looked at our Epic Fire API, and separate from a lot of internal use, we had about 3.6 million API calls over the last year to it. And the reality is, while we know who made the call, what we don't know is exactly how much data went and then what happened to those data. Those, of course, as you said, Andy, are in the purview of the individual with that third party. I think that's an enormous opportunity and a huge black box. And that, to me, is going to be very interesting as we all figure out what we do with just something as sort of straightforward as an open API.
So in our current iteration, we have suggested that read access to that content is what we're able to do. I think for us really to achieve what we're hoping to achieve, there will need to be write access as well. I don't think the industry is ready for that today. And I think it's in some of these, there are policy issues, and some there are technical issues. I think there are sufficient technical issues for write access that need to be solved before we go in that direction, but it's certainly a desirable outcome. And I think we'll make a substantial difference when we get there.
So if we look 3 years from now, let's say, what would success look like? How would you define success, that we've made the kind of progress we'd hope to by 2022?
Several perspectives. The first is think internal to your system, and the interoperability, the exchange of information between disparate groups of your own health system or practice that you've not been able to do to date. And there still are a lot of those challenges. We're replacing our PACS, but we're also building out a vendor-neutral archive. And the ability to have a PACS, a VNA, but then also an enterprise viewer for those who want to view images but don't necessarily need the power tools of a radiologist or someone else, just getting those systems to work more seamlessly in and of itself is one layer to look for interoperability. And I think you have to gauge what that means in your own health system. Then between your partner health systems, and then, again, one of the reasons for this conference that I think is so powerful, what are those 2 or 3 key things that we as a state will continue to want to focus on that we're still making happen within the state. I can then help prioritize that work in our health system, others would in their health system, and that's still a unique thing. So in 3 years, we have still continued to refine what those 2 or 3 key items are, because there are dozens of others. And internally, we're able to say we've moved the ball forward within our own segments of our health system.
For me, I have a large appetite of things that I would like to have happen. So I'd start with, we collaborated with CMS around some of the documentation requirements, made some proposals. They were met with some concern by various stakeholders. That concern was potentially not as informed as it might have been, at least when we looked at the entire Medicare, Medicaid databases. What we were proposing was actually pretty good. And the notion is that moving away from the federal government specifying what should be in a note and transferring the responsibility for that to your peers as represented by your specialty societies, perhaps your board, perhaps another entity like MedPAC or somebody, seems to me much more appropriate and would get us out of some of the burden issues that I've identified and we've talked about in our work. The second piece is this prior auth. Because prior auth has, if we solve the prior auth issue, there are some derivative things we can solve, such as price transparency and better machine learning applications. So and marrying the administrative or billing information with some of the clinical information, which is something we've not done successfully yet, I think will move us forward in a way that we can then start to look at the actual cost of healthcare and try and bring those down.
Thank you. We do have a couple minutes left. I wanted to see if there's anyone with a question or comment in the audience that you would like the panel to respond to. I think we have a mic runner. So maybe while we're thinking about that, I'm going to ask a question on their behalf. So we have a lot of stakeholders here representing organizations, part of MiHIN, et cetera, et cetera. What can you do for them, and what can they do perhaps for you to help with our shared goals, our mutual purpose?
Well, I hope you all did it by 11:59 p.m. last night, which is comment on our rule. One of the things people don't realize, and so this comment's for the next time we ask you to do it, but CMS puts out annual rulemaking, is the Administrative Practices Act specifies that federal entities doing regulation need to respond to all the comments that come in on a proposed rule. The good news is when people see stuff that they really like, the tendency is for them not to comment, just to assume it's there. And those people who don't like it tend to be very loud, frequent, and they comment in the negative. And then when the final rule comes out, then what happened to the part that I really liked? It's not there anymore. So that's one piece of advice. TEFCA's, just like the clinician burden report, not in a formal regulatory cycle. So there still is plenty of time to comment on TEFCA. There is a lot of aspects to the revised TEFCA that we would appreciate you commenting on, thinking through. How will TEFCA play in Michigan? Do you need TEFCA in Michigan? And is there something about what we've proposed that we can make better when we finalize it? And remember, this is a proposal that is a public-private partnership. How is Michigan going to play in that space? Where do you see yourselves playing? So those are two things that I'd comment on.
How about for you from your perspective in parts of the state that you're working with?
Well, I'm sorry that I wasn't able to be here earlier, so I don't know if this has been done, but I think that forums like this are good places to do, even if it's just straw polls, of what are those, like I've been saying, those 2 or 3 key items that are important to you that we could ideally see where we have enough commonality and just stay focused. We're in healthcare, and many of us have the idea of the enemy of good is better. let's avoid that. Let's stay very focused, show that we can get a few things done. I cannot overemphasize how unique I think the state of Michigan is to be able to do that. There are very few other states, Indiana, maybe Maryland with CRISP, that have this kind of state coordinated infrastructure. I think Blue Cross plays a big part of this for us. I think MiHIN, I think GLHC. We have some wonderful organizations, and frankly, I think we do have some probable support from the feds that we probably could also try to leverage a bit more, so that we're saying these are the 2 or 3 items that we want to focus on. I know we're all dealing with opiate and opiate prescribing and how we can use MAPS and how we were reporting with APRIS to do it. I know that ADT, in a manner that really helps the provider organizations, is something that we are working on, that we have pretty good examples. Is it good enough? I've mentioned images, but those are, again, just examples. They're not necessarily the 2 or 3, but that kind of conversation, how we use this group to prioritize, how we use the MHA, how we use MiHIN, GLHC, and these other groups to say, here are the 2 or 3 priorities that we all want to focus on. Then we bring those back to our own organizations and make those the priorities. And then when we come back and reiterate on that. Otherwise, we will diffuse ourselves with all the other things going on. And we won't really make that kind of collective improvement. It's basic blocking and tackling. There's nothing innovative in what I've said. It's how do we use these organizations to move that forward.
So thank you. Clearly, focus is part of how we make great progress in areas that are the most important to us. I'd like to thank both of our speakers for their part in the presentation, and I think we're at the top of our hour, so if you have any other questions, I'm sure they'll be happy to help offline. So thank you very much.